Good evening and welcome to the Hemophilia Federation of America Families webinar. This is our fourth and final webinar of the 2015 year. We're looking forward to tonight's presentation. My name is Sandra Wilkes. I'm a program manager at HFA for our Families program, which includes Dads in Action, Moms in Action, and Kids in Action. Elaine Chan, our program coordinator, is on the line with me tonight to help with some logistical issues. But again, just want to thank everyone for attending. And get ready to begin. So a few pointers and helpful hints. Tonight's webinar will last approximately 1 hour. We welcome your participation and questions. However, your audio will be muted by our system for the duration of the webinar, as this helps us eliminate background noise that may disrupt the presentation. If you have a question, we encourage you to use the question box on the bottom right of your control panel. I will then pass these questions along to our speaker. Throughout tonight's webinar, we will be asking the audience for your input during case studies. So please use that question box on the control panel to participate and be part of the conversation. There are also several audience polling questions tonight's webinar. When those questions appear on your screen, you'll have the opportunity to answer those anonymously, and we will then share the audience's feedback. And then finally, HFA would like to acknowledge Novo Nordisk, the Centers for Disease Control, and AHS for their support of our Families program. Our speaker tonight is Dr. Alex Green. Dr. Green grew up in the Bay Area in California. She went to college in San Diego, medical school in Chicago, and is now a second-year emergency medicine resident at the St. Louis University in St. Louis, Missouri. Dr. Green has a twin sister who she is very close to. Her family is all in the psychology field, and they live in California, where Dr. Green hopes to move back one day. And with that, I will pass it off to Dr. Green for tonight's webinar. Doctor, give me the news, communication, in the emergency room.
Hi, I'm Dr. Green. I'm going to be discussing with you guys a little bit about how the emergency department works as a whole, and how you can be most effective when you present to the emergency room with yourself or your child in terms of a bleed or some sort of infection or any other reason that you would be coming in. The objectives that we're going to be covering tonight is how to empower patients and parents to advocate for themselves in a positive manner, and how to speak up when an experience does not go smoothly in the emergency department. We want to encourage patients to plan ahead for these emergency visits by being prepared to give a good history and explanation of their disorder and why they're coming in. And we want to be able to teach patients and parents some of the basic functions of how the ER works.
So we're starting tonight off with a poll question, and we'll go ahead and launch that poll. How often do you have to visit an emergency room for yourself or your child? So audience, if you will take a few seconds here to go ahead and vote. Just about everyone's voted. We'll give it just a few more seconds here. All right, our audience has completed voting.
Okay.
And let's see. Dr. Green, every 6 to 12 months for about 2/3 of our audience, and then the remaining third is less than once a year.
Oh, good. Okay. Okay.
Whoops. There we go. Oh, and we have another poll question. Let's go in and do that one. What are most of you or your child's ER visits for? Give the audience a second to vote on that one. Great, everyone voted quick tonight. This is the season, right? Again, 2/3 of our audience says to rule out a major bleed, like a head bleed or gastrointestinal bleed, and the remaining third is for accident, trauma, just normal kid stuff.
Okay. So next we have a case study that we want to discuss. you have a 2-year-old boy that comes in with severe hemophilia A, and he is running through the house with his older sister and falls and bumps his knee. A bruise immediately begins to form. There's swelling, and the boy is crying uncontrollably. The mom brings the boy into the emergency room for an infusion because they have not learned home infusion yet. When the mother and child arrive in the ER, the mom is frantic with worry and begins demanding immediate treatment. The ER staff begins the intake process, and mom is now hysterical, screaming he has hemophilia. How could this ER visit be improved?
So audience members, if you could share maybe some of your thoughts how this emergency room visit could go a little smoother. Maybe you've been in those shoes before. I will be happy to share that input with Dr. Green. One comment is that mom could have called the HTC first and asked them to forewarn the ER that she's coming in. How does that help you guys in the ER, Dr. Green?
I think that can be very helpful so that we can be prepared and we can let the nurses up front, maybe in triage, know so that they can be aware that this could be some kind of major bleed, or they could help call maybe the pharmacy to let them know that we may need them to start mixing factor if that's something that's going to be needed right away, because that can take time. So it's just helpful to let everybody know in advance.
What about letting the, or how mom's reacting? Is mom's frantic worry kind of helping or harming the situation here?
I think it can be somewhat detrimental to what she's trying to get across. If she stays calm, it's easier for everyone to stay calm, including the patient, because a 2-year-old, while being young, is still able to gauge someone else's reaction. And the more that she is upset, the more it can cause the patient to be upset. And it can also slow down, the care, because people won't be thinking as clearly or moving as quickly.
Great. Okay, well, I don't have any more questions or comments from the audience. Anything else that you can add, Dr. Green, in terms of how you guys would assess someone coming into the audience or into the emergency room in this kind of situation?
I think realizing that the ER has a protocol and steps that must be followed, and that we have an order we see patients in using our triage system. So there has to be an understanding that you can't expect to just walk in and within a few minutes get transfused. You have to kind of expect there to be the system that takes some time, but that based on, how critical we think the bleed could be, we do understand that it's emergent, and we're going to, get them in as fast as we can.
Okay, great. Thank you.
So being an advocate for yourself or your child is obviously very important. Bleeding disorders are rare, and many healthcare providers, while knowing what the disorder is, may not have encountered too many patients with that specific condition. So you as the parent have the most knowledge about the disorder itself and your own child. So helping relay that information effectively is going to be the most helpful. So there's nobody, that we want to help more than the child itself, but you yourself are going to be the person who's the most interested in the care of your child. So if you can relay to us in a concise manner the key points of what type of bleeding disorder does your child have, what their current treatment regimen is, what factor they use, and how they usually respond once they have the infusion. And then some other major comprehensive facts that could include, does your child get treatment prophylactically, or do they just get it when there's an active bleed occurring? Is your child behaving normal at the time that you bring them into the ER, or have they started to behave abnormal? So we can be aware of looking for any major head bleed if they're not acting like themselves. Another thing is, just being very clear about the exact events that took place prior to this visit, such as did they hit their head, did they fall off a bike, if they fell off a surface, how high was that surface, just kind of trying to explain the exact scenario that took place and the mechanism of the injury clearly is very helpful. So remembering that, again, we do know a little bit about hemophilia as the treatment providers, but you know a little more. So just keep in mind that we don't know your child's treatment plan. So if you guys know it, please relay that effectively. And if you know signs or symptoms that the child has when they are having a bleed, maybe if there was not a traumatic event that preceded it, it's helpful if you relay that to the treatment provider so that we can recognize if there is a bleed as well. And then we have another case study. You have an 8-year-old girl who has von Willebrand's disease, who has a nosebleed on a Saturday afternoon that's lasted for 30 minutes with no signs of the blood flow slowing down. The dad calls the hemophilia treatment center, who recommends that the child be brought into the ER to be seen. The dad balks when the last ER visit took 8 hours because the pharmacy at the hospital did not have his daughter's medication in stock. How would you recommend that this ER visit be improved?
So again, audience, we're looking for your feedback here. Again, many of us parents with children with bleeding disorders may have been in a similar situation. So any feedback on how this ER visit could be improved from the audience? I see typing happening. I just don't have it up yet, Dr. Green, so I'm going to give
no problem.
To finish their thought. So one parent on the line says, if allowed, taking the factor into the hospital with you. So do you want to talk about that? I know that's been an issue that we hear across the country, kind of being different depending on your facility. If you're allowed to bring factor in, is that a good scenario for you guys in the emergency room?
It is something that we have experienced both with hemophilia and other medical conditions in which people bring in their own medications from home. There is no standard of care across emergency departments. Many times with most medical conditions, we do not allow patients to use their home medications. But in a scenario such as hemophilia, in which the hospital that you're at may not stock the required medication, some centers may allow you to bring your own product. It's sort of going to be hospital dependent, but I think it's always best to recommend that you do bring your own product if you have it with you, even if you don't know how to mix it yet, or you're running low, or you're not sure how much to infuse. It's always best to bring it with you, so at least the pharmacy can see if they have that exact same one, or they can use your own factor. At the end of the day, it's going to be most important that the factor they need gets to the child as fast as possible. So if it's going to help speed up the process, it's always good to have your own there with you.
And what about in terms of diagnostic testing? I mean, should parents be worried about that? I know for me personally, maybe I forget about that aspect of it.
Yes, I think it's easy to, kind of be blindsided by the fact that you have a bleed, and that the most important thing to stop the bleed seems to be getting the factor in and, getting it to slow down. But in a scenario like this one in the case study, when you don't know exactly how much blood has been lost from the bleed, it's important to make sure that we can also get some diagnostic tests like a CBC, where we can see your hemoglobin to see whether you've had immense blood loss and could require red blood cells to be transfused. in addition to some other testing, like if you're worried about a brain bleed, yes, you want to stop it with factor, but we also need to get a head scan or some imaging like x-rays with joint bleeds in addition.
Okay. Anything else that you as a provider think could help improve this ER visit or this experience for this family?
No, just, realizing that unfortunately wait times in the ER are long, and we do our best to get you in as quickly as possible. And while 8 hours does sound like a very long time, maybe during those 8 hours while they were waiting for the pharmacy to get that medication, there was also diagnostic tests probably being done. And so things are happening. It might just take a little longer than, people would want.
Okay, great. Thanks.
So when you are heading to the ER, it's best to plan ahead. You can do that by being aware of your insurance. You can bring things with you like toolkits that we'll talk about in an upcoming slide. And if you do get stuck waiting after you're triaged, it's good to ask why you're waiting. So you can find out, if there are a couple traumas or other very severe patients ahead of you that are taking priority at that moment. Also, if there is the chance that your child has a possible bleed, you want to be persistent, and if possible, to get that factor infused before the patient goes to imaging for a CT or an X-ray. That's also very important, because our usual standard of care with a lot of patients is to get imaging before we provide any medical treatment, so that we can have a better idea exactly what's going on. But hemophilia would be one of those few scenarios where it's important to do the opposite and get treatment before more diagnostic tests. Also calling ahead to find out from either your treatment center, or if you can call the ER directly when you're on the way, to ask them whether they're allowed to use their own factor. Can also be helpful. Some insurance plans do require that patients call them immediately in the case of going to the emergency room, and they can deny claims if they aren't notified right away. So just be aware of your own insurance policy so that they can be updated in a timely manner and you can get the most coverage possible. And then another thing is a lot of parents can be concerned about wasting their home factor if they were to bring it, but it's better to get some factor in your child as fast as possible rather than risk losing some of the factor you have by giving it to them in the ED and not having the hospital use their own supply. If you're able to mix your own factor on the way to the ED and use it, that's also something you want to find out, because maybe you can speed it up by having it ready to go right when you get there. If they don't allow you to use your own factor, sometimes patients worry because it does take longer, but there are often pharmacy staff available in the EDs that can promptly come into the room and find out a little bit about what you use and how much, and they can start mixing it for you immediately if it's available. Another thought that could help speed up the emergency room process is to create an action toolkit in which you have some materials to work with while you're stuck waiting. Some of those include bringing your clotting factor, which we discussed, having an ice pack, bringing a happy bag that can have toys and different things to entertain the kids, include your siblings as well, important comfort items, maybe food, snacks, phone chargers. And then another thing would be having a folder of information ready, such as a letter from your hemophilia treatment center, the MASIC recommendations, an infusion log, the hemophilia emergency care.com booklet, have a car seat sticker, a phone charger, an ID card with a medic alert, and the phone numbers of each of the providers that your child sees, like the hemophilia treatment center, their pediatrician, their hematologist, the pharmacy they get their meds from, and the home care company that they get their meds from.
And we have another poll question. And before I launch that poll question, I will just remind the audience that you do have these handouts that were just previously talked about. They should have been emailed to you tonight, just prior to the webinar beginning. But if not, just let us know at HSA. We'll be sure to get them to you. But here is our next poll question. And the question is do you have an ER action kit? We'll give everybody a few seconds to vote and see if anyone has them. Just a few more seconds, and it looks like I need there we go. Now we have 100% of our audience. And it looks like we're a third across the board. Yes, we have a toolkit. No, we don't have a toolkit. And no, but I'm going to put one together after hearing this.
Okay. That can be something that can be very helpful in the future. Okay. So next we have another case study. A 13-year-old boy with severe hemophilia B and inhibitors has been treating a knee bleed for the past 3 days at home. He was seen at the Hemophilia Treatment Center at the start of the bleed, who developed a treatment plan for him, and he and his parents have been following it precisely. His pain has not been improved and is in fact worsening. The boy asked his parents to take him to the ER. His parents called the Hemophilia Treatment Center to let them know the situation. The center advises going to the ER for pain management, possibly IV narcotics, and admitting the boy for observation. Upon arrival in the ER, the boy and his family are told to wait in the waiting room until a bed becomes available. They wait for 2 hours in the waiting room with the boy writhing in pain. When it becomes time for the next infusion, which mom or dad or the boy can do independently, they are still in the waiting room, which is full of sick children. What could be done to improve this visit?
So again, audience, this is your opportunity to share how you guys might feel this ER visit could be improved. So one suggestion is, can the parents ask if there's anywhere that they can just step aside or step in and do that infusion while they're awaiting a room, possibly?
Definitely. Emergency departments almost always have a family room available where we have the physicians come speak to families in private about their child's care or, just to discuss the plan of treatment. So there should be somewhere for you to go. Another thing could be asking the staff to get a pair of gloves maybe so that you can help prevent germs from being spread that could be just on, your hands from sitting around sick children or in that area.
Yeah. Another suggestion is having the treatment center call to the emergency room ahead of time. We've talked about that already. What else, Dr. Green? What else would help make this ER visit go a little smoother?
Make sure that you really emphasize in a case like this that the patient is severe, and if the pain is worsening, sometimes they can even administer at least oral pain meds up front, usually not narcotics because that requires patients to be on a monitor of their vital signs. So be aware that that's one limiting factor if you do get stuck waiting, and why we don't give narcotics or really strong pain meds in the waiting room in advance, even if someone's in pain. Just try and, communicate effectively that the bleed's been going on for several days, the pain's been getting worse, and that if they are due for an infusion, let the staff know that following their current schedule, they do need to do that and see if maybe that could even speed up getting a room inside the department.
Okay. I don't have any more suggestions from the audience. I think, again, I personally would suggest asking if it was necessary to call the Hemophilia Treatment Center on-call number again, and maybe giving the on-call hematologist a heads up to see if they can maybe call the ER and help speed things along too. I don't know if that helps or hinders you guys in the emergency room, but as a parent, I think I would try that tactic too.
Yeah, it's always helpful when another doctor contacts us. We, obviously respect our colleagues and whatever they recommend, especially when they're the specialists in a scenario like this. If they tell us that this patient needs to come back and take priority over, maybe some of the more sick patients in the ER, then that's something that we definitely want to be aware of. And in a case where the kid's severe, that may be true. So it's always helpful to call them and have a hematologist call us.
All right, thank you.
So some other tips that may be helpful when you're raising a child with hemophilia is don't allow yourself to be treated poorly in the ED. Always ask lots of questions to both the doctors and the nurses. Remember that the scans are usually less important than getting factor, and that might be something that somebody who's never treated a hemophiliac may be unaware of. So do try to relay that information. Educate your doctor or your treatment providers about what you do know. Have supplies with you, and ask the nurse maybe in advance whether they do know how to mix factor. Remember to stay calm. If the nurse does not know how to mix factor, which may be a common thing that you encounter because it's not too frequent that we do this, remember that there are pharmacists available. Emergency departments always have a 24-hour pharmacy, so they do have people on call at 24 hours a day, and they will have a greater knowledge of how to mix these kinds of factor and administer it. So if you don't know as the parent, there are always backup resources available. Next, we have another poll question.
Yeah, so we'll go ahead and get that launched. And just asking the audience, there's a typo there, sorry about that. What do you think the average wait time in an ER is? Our audience, just a few more seconds to vote here. And see what our results are. 2/3 of our audience believes that the average wait time is between 45 and 60 minutes. Dr. Green, what is the average wait time?
That is correct. In 2009, the CDC reported the average wait time was around 58 minutes. The wait time, just to clarify a little more for you guys, what's included in that wait time is the difference in the time between the arrival to the ED and the time that a patient is seen or has initial contact with either a physician assistant, or a nurse practitioner. Your treatment time is defined as the difference between the time that the patient has initial contact with the treatment provider and the time that the patient actually ends up being discharged from the hospital or admitted to the hospital. And we use triage systems that include a 5-point scale between 1 through 5 to decide how emergent a patient needs to be seen. The point scale includes number 1 being the most immediate, 2 means it's emergent, 3 means it's urgent, and that's going to be the greatest population that we see in the ER. 4 is semi-urgent, and 5 is non-urgent. And this system was created to be effective in trying to get patients moved in the department most effectively.
Dr. Green, we're not currently seeing your screen, so if we can.
Sorry.
That's okay. Yeah, if we can try and go to slide 15, I believe is what we're on. Perfect. Thank you.
Sorry. Okay. Okay.
And this is our next poll question. And what is the average total amount of time spent waiting plus treatment in an ER? Let's launch that poll. And that was a very quick response there. So 100% believe that it's 2 hours or more.
Yes, unfortunately, that is true. The average wait time is 2 hours and 15 minutes. And I think that's actually impressive because I think the average is probably more like 6 to 8 hours when you're actually there.
Okay, we'll be on slide 16.
Okay.
These are our webinar hiccups that happens. No worries.
Are you able to see it?
Yep, we are right where we're supposed to be. Excellent. Thank you.
Okay. So understanding the anatomy of how an emergency department works can help you be aware of what to expect. There's always going to be a check-in registration area, and usually within that same region, we have our triage nurses there. They usually triage based on that 1 through 5 system I just went over, and they usually obtain vital signs that also take a part in deciding what their triage level is. They don't usually do diagnostic testing until you get a room in the back of the department, and often the history will have to be given to multiple staff members, so that's something to be aware of that can be frustrating at times, but if you expect it, it might make it a little less aggravating. You're going to have to repeat the story initially in triage, and then again to the nurse who's helping you, and then possibly a third and fourth time to either a resident doctor and then the attending physician, or just the doctor in charge at that time. If you realize while you're in the waiting room that there are many people being seen before you, it's probably because those are the sickest patients. But if you feel that you're being overlooked or that somebody is less sick than your child, then you want to be proactive and speak up as often as possible. And if you start to notice that your child's condition is changing or worsening and you need to be seen right away, do not be afraid to speak up and tell the nurse immediately. So here's another case study. A 10-year-old boy with severe hemophilia and an inhibitor suffers a deep 1-inch cut above his elbow. The mom does basic first aid for the cut and begins applying pressure. The cut is bleeding profusely. While dad holds pressure, mom mixes the factor and infuses her son at home. She calls the hemophilia treatment center for further guidance, who advised taking the patient in to be seen in the ER because he may need stitches. Upon arrival to the emergency department, the boy is seen in triage, where the nurse replaces his pressure bandage and advises that they may have to wait. Apparently, the ER is extremely busy because of a local fire in an apartment building and is actually diverting ambulance traffic. The bleeding is not stopped, but is slowed down. How can this ER visit be improved?
So again, audience, welcome your feedback here. I think it's interesting. Dr. Green, you talked about the different levels, the non-emergent, urgent, all those different triage levels. What would this be categorized as?
I would say this would probably fall as a level 3 because it is the elbow. It is important, of course, but it is not a life-threatening illness. And it would be considered probably, something that needs to get in sooner than many other patients who aren't having an active bleed, but it's not critical that it go above traumas or patients who need medical resuscitation or things such as that.
Okay. What else can the parents do maybe while they're waiting in the emergency room to be seen? What can they do to help
you can always,
in this situation?
Holding pressure is the #1 way to stop a bleed, even if you are a hemophiliac. that's going to be the best thing you can do, is to just make sure that even if you applied pressure for a little bit and it didn't work, that you don't get discouraged and just stop applying pressure. It can get tiring, of course, so you can take turns having the child hold it with his other arm, or each of the parents hold it separately. That can be helpful. And if the mom already infused factor, maybe calling the hemophilia treatment center while in the waiting room to see if the dosing was appropriate or whether more needs to be given than his standard.
And I guess the other question here would be, is this something that could maybe be seen in an urgent care facility, or if the wait is going to be particularly long, say they're waiting in a children's emergency room, is this something that maybe could go to a general adult facility?
Yeah. I think this could be seen in an adult facility. I think it could be also seen in urgent care. If they gave the factor already and they don't feel that any more, or the treatment center doesn't recommend more factor, they just recommend stitches, you can definitely be seen in an urgent care. And if you have called ahead to the ER, it might be beneficial if they say they are diverting to other hospitals, if you find out maybe some other ones close by, and go to those instead.
Okay, excellent. Well, we can move on. Thank you for that.
Yes. Next, we have a poll question.
We sure do. So, and this is actually our last poll question of the evening, I believe, and asking the audience, have you ever had a negative experience in an emergency department? We're just waiting on a couple of more votes here. There we go. And it looks like 2/3 say yes, but they just chalked it up to an inexperienced medical staff. The other third of our audience says yes, and I followed up with my HTC or hospital staff.
Okay. I'm sorry that is the experience that you guys have had. Hopefully we can find ways to improve it from using this presentation to help improve your visit. So the things to know if you do have a negative experience is to remain calm. Being upset and frantic never really helps the situation. Always be assertive and persistent. Speak up. Don't accuse people of being unknowledgeable. We don't see hemophiliacs very often. So if people seem like they are inexperienced, that might be true. But the best thing to do is to work together as a team to relay the information that you have about your child up front and in the most effective manner. The other thing to be aware of is that when we see children that have lots of bruises, we do have to rule out that we don't feel like a child is being abused. And if you just clearly state, that they are a hemophiliac and that these bruises are similar to the ones that they get frequently or with their bleeds, that can be very helpful so that we don't pursue that path of thinking that abuse is on the differential. That can lead to unnecessary scans being done if we do suspect that. So just make sure you're upfront about it. You are going to be your best patient advocate. And it's also helpful to carry around a letter from the Hemophilia Treatment Center or a medic alert bracelet so that you can kind of prove the hemophilia up front just in case there is any kind of questioning. Okay? And then remember that you do have to tell your story several different times, and when you expect it, it makes the experience a little less aggravating and negative. Next, we have a resource library that Sanji is going to tell you about.
Yeah, so HFA recently redesigned our resource library on our webpage, and it's got a lot of great information on there. Coming soon, though, is a toolkit that will be dedicated to emergency room and hospital visits and just making those go a little smoother for parents and for the children involved. All of the handouts that we sent earlier tonight will be in that toolkit, should be up by mid-November. Also in that toolkit is a document that we will have that's already on our website called the Bleeders Bill of Rights. And actually this was developed by a working group with HFA volunteers who saw the need for kind of giving patients a document that really reinforced what your rights are as a patient. We've had several stories of people using that when they go into an emergency room and really just kind of reinforcing and giving them the confidence to be a better advocate for themselves and for their child. So that's available on our website. When you get a follow-up email from us after this webinar, we'll include a link to that page so that you can access that quite easily. And then just be on the lookout for this toolkit coming up in mid-November. But with that, we have quite a few minutes left here for any questions from the audience about making emergency room visits go smoother. I think those of us that have children with hemophilia or other bleeding disorders have generally been there, done that in the emergency room, and have had some pretty okay experiences and some not so great experiences. And if anyone is wanting to share any of those experiences, maybe talk about how that's gone for them and what made it better from them, that would be great. I think I see one comment coming up, so I'm going to try and get to that and answer that question. But yeah, Dr. Green, anything else that you would like to add?
Just remember that, we all have the same goal in mind. The treatment providers and you all want the same thing, which is the best care for the patient. So if we all work together as a team, that's going to be the very most effective method to treat them efficiently.
Okay. I see that one participant has their hand raised, but I don't see a question in my text box. So that participant, there we go, it just popped up. Here we go. If a nurse has difficulty accessing your child's veins, should he or she be allowed to continue to try?
This is kind of a common thing that happens. Nurses do, get access and do IVs more frequently than doctors by far. Doctors have other techniques available to them that the nurses may or may not know how to do, such as using like ultrasound-guided IVs to ensure, that you can see where you're inserting the needle. So if you feel that, the nurse has tried more than what seems reasonable, like 2 or 3 times, you can always ask them to get another nurse. Sometimes in the department there are some that are known to be sort of experts at it compared to the average nurse. The charge nurses usually have been in the field longer and have a little more experience, so sometimes they're available. And then, of course, the doctors are always there as backup and can use other techniques. But if you feel your child's been poked more than, 2 or 3 times, then you can always ask for somebody else to come try.
And how do you as providers feel about either the parent or the patient themselves accessing their own veins if they can? Maybe they're not there necessarily for access of a vein, but they're there for those diagnostic tests. Is that generally okay in your facility?
I have to admit I've never encountered that scenario. So I don't know exactly how different doctors would feel. I think if you're doing it for diagnostic testing, it might be something that they'd prefer a provider do. But if it were to be for factor, and you know where your best veins are and where you usually go, that might be something they'd be more okay with.
And this mom followed up by saying that they allow a nurse 3 times, and after the 3rd strike, they're out. Someone new either has to come in, or her son just go ahead and infuses himself. So,
I think
that's pretty standard. Yeah.
Mm-hmm. Yeah, I think that's completely reasonable.
Awesome. Any other questions from our audience? I'll give everybody a second here to type. I guess another question for you, Dr. Green, would be, how do you determine when to go to an emergency room versus when to go to an urgent care facility?
That can be sort of difficult. I think if you have a need to get factor, then almost always I would recommend an emergency department rather than urgent care. A lot of the time they don't stock urgent cares with many rare medications, so you would probably want to go to an ED in that case. If you have a bleed, or not a bleed, but maybe a bleed similar to one that we presented in that case where you've given yourself factor and you're concerned that you may need stitches, and you called the Hemophilia Treatment Center and they say that you don't require more factors, that's a good instance to use an urgent care. If you're concerned about a port being infected, that's something that also an urgent care might be able to manage. They know what signs and symptoms to sort of look for, and they will transfer you if they feel that you have an infection and need IV antibiotics instead of just antibiotics to be sent home with. If you ever have a child with altered mental status due to a potential fall or bleed, definitely come to an emergency department. If you feel like there's been quite a bit of blood loss from a bleed, also come to the emergency department, because I'm not sure whether urgent cares can transfuse blood and have blood banks available to them the way we do in an ER.
Okay. How often do emergency departments kind of interact with hemophilia treatment centers in terms of ongoing education?
Unfortunately, I would say probably not that frequently. I am an adult emergency physician, so I can't say, that I know a lot about what the pediatricians or the pediatric side does. I know that the one I work at, Cardinal Glennon in St. Louis, has a hemophilia treatment log where they can keep track of their frequent flyers of the children they see commonly in the ED, so that they have access to their history, their infusions they've gotten, and the complications that they've had available to them easily. I think some of the more academic centers may be better about communicating with the hematologists and the treatment centers.
Okay. And then we have another question about medical IDs, medical alerts. You mentioned those earlier. How often do ER staff notice them or check for them?
If you come in as a trauma patient, if you were to be involved in a major motor vehicle crash or any kind of major trauma, the protocol is to take everything off of the patient until they are naked. And in that case, if they're wearing a bracelet that looks like a medical one, or I've seen in the past actually people tattoo, they're, something indicating they have the conditions on them, they will most likely be seen. Unfortunately, if you don't have your child change into the gown and sort of get down to like the bare bones of it all, it may be more difficult for the staff to see it. Children are a little bit smaller and, don't tend to have as much stuff on them, so it's a little probably easier to see in that case.
Right. And I think it's, I think the medical alert thing, that whole issue is sometimes difficult for parents to navigate. There's lots of different types of medical alert identification methods out there, from anything from the shoe tag to the bracelet to the dog tags around the necklace. I know I've always been told that a necklace or a bracelet are much more easier, more likely to be seen. So
I agree with that. I think the shoes, his personal opinion would be that that'd be the least effective, because we almost always have you take off your shoes, or the nurse takes them off immediately, and they almost get overlooked, I'd say, 90% of the time. So it may be best to have something that's a little easier to identify, such as the bracelet or dog tag.
And then you guys do call the 800 number that is on that to obtain information, correct?
Yes, as long as we see it, somebody definitely will call to find out more if it's something we think, we need to know further.
Okay. Well, at this time, I do not have any more questions from our audience. We have a few minutes remaining. We'll go on and go to the next slide. And if anyone has any further questions, don't hesitate to go ahead and type those in, and I'll keep my eye out for them, and we can always pass them along before we're done here. But we'll start wrapping up this evening and just saying, the HFA really believes that patient advocacy is really huge, and it really does begin at home. And so we encourage families to take action. You did that tonight by being here, being involved, asking questions. Really look out for those resources. Use your local member organizations, and feel free to reach out to HFA for resources and assistance through our website or through our social media avenues. You can go on and go to that next slide for me, Dr. Green.
Sure.
Yeah. We have an active social media presence with HFA. Please like us on Facebook, follow us on Twitter. We're also on Instagram and Pinterest, and share a lot of our resources that way. I think our bleeding disorders community generally is very well educated and is looking for those resources, and I applaud all the parents on the line tonight for being here and doing that. If anyone has any further questions, there's the email addresses to reach out to us. We will be having a couple more advocacy and general webinars later this year. But this does end our Families webinar series for 2015. Be sure to join us in 2016 for some important topics coming up next year. But without seeing any other questions, I think that is going to conclude us for tonight. Dr. Green, I thank you so much for sharing your expertise and giving us some insight on how the emergency department works and how we can be better advocates as parents and patients with bleeding disorders.
Of course. I'm happy I could help.
All right. Everybody have a great evening. Thank you again for joining us, and we look forward to seeing or hearing you soon at HFA. Thanks so much.